I'd like to welcome Mark Geier and David Geier. Mark Geier is a medical doctor and a PhD in genetics from George Washington University. He's a fellow of the American College of Epidemiology. He has nearly 200 publications in academic journals and medical textbook chapters. He was previously a research scientist at the National Institutes of Health for over 10 years. He was an assistant professor in the Department of Gynecology and Obstetrics at Johns Hopkins School of Medicine and an assistant research professor at the Uniform School of the Health Science. He's been in private practice in medicine for more than 33 years with medical offices across the United States. He was invited to address the U.S. State Department for an institute regarding contemporary genetics, the Institute of Medicine of the United States National Academy of Scientists on multiple occasions regarding vaccine safety and policy, and the Government Reform Committee of the United States House of Representatives on mercury and vaccines. He was an accredited participant in the Intergovernmental Negotiating Committee meetings of the United Nations Environmental Program to help prepare a global, legally binding instrument on mercury, the Minamata Convention on Mercury. He is currently the co-director and co-founder of the nonprofit Institute of Chronic Illnesses Incorporated. Please welcome Mark and David Geier on the Zoom meeting up on the screen.
Hello. Thank you for inviting us. Sorry I couldn't be there, or we couldn't be there in person.
Dental amalgam fillings, based on assessment of the NHANES data. The next one. Now, one of the issues about dental amalgam fillings is the link with the problem has always been one of we have great data about fillings and the potential release of mercury from them in animals and even human data, but the question is about following populations over time to be able to determine whether there's indeed any risk to various human chronic diseases as well as organ systems. And so that has always been the missing link. The new research that we've been engaging in NHANES bridges that gap. The NHANES, or National Health and Nutrition Examination Survey, provides us a unique ability to do that. NHANES, as the slide shows, is a program of our government, specifically the Centers for Disease Control and Prevention's National Health Center for Health Statistics branch that administers the NHANES. The next slide. The NHANES is a major program, as I mentioned, of the National Center for Health Statistics. It is designed specifically to examine the health status of the U.S. population, methods and modes of testing involving interviews, physical examinations, and laboratory tests. The NHANES origins go back to the early 1960s. But in 1999, it became a continuous program, meaning that on an annual basis, the CDC began examining Americans for their health status. The NHANES examines about 5,000 people each year. The data is reported out in 2-year spans, so roughly 10,000 Americans are produced on each cycle of the NHANES data. And the NHANES program's specific objective is to develop public health policy from it. So it's not like the kind of studies that we're doing looking at dental fillings and chronic disease is something outside the scope. It was specifically designed to do that. And the latest development is that in the 2015-2016 NHANES, for the first time, not only were cavities and fillings recorded, but specific material was recorded as to the teeth status of people. So we could compare dental amalgam fillings versus other dental services. Or that we looked at in our studies is arthritis. Next slide. So as we all probably know, arthritis is autoimmune disease. So that was our exposed group.
Okay.
So this explains, this is a flow chart that shows you the overall data in NHANES that was examined from the 2015-2016 NHANES. As I mentioned, we started with a overall population of people there were 9,971, as I said, roughly 5,000 people a year are examined. When you apply the weights to that, to how it's representative of the US population, it translates to 316 odd million people, which is the whole US population. Then within that population, a subset completed both oral health examinations. So in other words, their filling status was evaluated. That eliminated a few people who didn't go that far. The next cut was more significant. That's where we examined people from the ages of 20 to 80. So we're examining the adult US population, as well as a bunch of information about their demographics. When we make those cuts, we end up with just shy of 200 million people, which is in the actual number in NHANES, almost 4,400. And then this is followed by, among those, we wanted to know their arthritis status, and we only wanted to find people who were recently diagnosed with arthritis. Those who had been diagnosed many years ago, as I mentioned, were eliminated. When we make those cuts, the overall population is about 165 million people. And then within that group, we split them into two groups: those who had one or more amalgam filling surface, as well as they could have other fillings. That was roughly 86 million people. Those 86 million people, based on their age, had a follow-up time of almost 3 billion years, meaning from when they were born to their current age. That's how long they had been followed. The people who had no amalgam fillings but one or more other surfaces than amalgams, roughly 32 million people, contributing 1.1 billion years of follow-up time period. And then overall, when we assess for arthritis status, which is the bottom ones, 2.5 million ended up with arthritis, newly diagnosed arthritis in the amalgam group, versus 124,000 in those who had no amalgam fillings. Next. In order to do our analyses of the populations, comparing those with amalgams versus those who didn't, this is the basic premise of what we did. We used what's called survey logistic regression and survey frequency modeling. These are sophisticated ways to basically look at exposures and outcomes. I'll show you more as we go along as to what the actual modeling did. As part of that modeling, we assumed as our null hypothesis that there would be no difference in the rate of arthritis regardless of dental amalgam filling status. And we accepted a p-value less than 0.05 as significant. We also evaluated the amalgam filling surfaces in a dose-dependent relationship with the outcome of arthritis. The idea being that maybe a contribution of more and more mercury exposure from amalgam fillings might increase the risk. Now, this is often seen in biological systems, and we wanted to test that in our analyses as well. Sorry, there's a lot of information in this, but this is a complete demographic overview of the two different populations. On the left-hand column are the dental amalgam filling surface group. So again, those are all the people that had one or more dental amalgam fillings. The right-hand column represents those who had no amalgam fillings but one or more other surfaces. As you can see, we're examining adult population, fairly equal breakdown among those with amalgams for males and females. But interestingly enough, those who don't have amalgam fillings tend to preponderate towards females. So as we go through this, and I'll quickly just summarize, you'll notice that there are actually differences, key differences, because this is a basic kind of demographic question that we've all been interested in. Who gets amalgam fillings? Who does not? Who makes the choice not to get them? Well, females probably for cosmetic reasons, perhaps, hopefully, we can think for health reasons, try to avoid amalgam fillings. The racial breakdown is kind of interesting. There is slightly higher whites, non-Hispanic whites tend to receive dental amalgam, 66% versus 62% among those who those who don't have amalgam fillings. Among Asians, we find that there are more Asians who tend to avoid amalgams relative to whites. So very interesting about certain racial demographic effects. Where people are from, slightly more are born in the United States who tend to have dental amalgams versus slightly fewer tend to avoid dental amalgams. And on educational status, we see that people who are most educated tend to avoid dental amalgams. There's 41% are in the college graduate and above, with those without amalgams, versus only 35.5% in those with dental amalgams. As far as socioeconomic status, that doesn't seem to really play an effect in this data. There are similar values in both groups. And overall, at the bottom is the weighted frequency based on the age of people of arthritis. So it's 6.2 per 10,000 weighted person years in the dental amalgam group versus 1.06 in the non-dental amalgam filling group. This is now an actual output of the models that we calculated. The important question that's being asked in this particular survey logistic regression model is to compare those with dental amalgam filling surface group versus those who are in the other dental filling surface group for the outcome in this case of arthritis. And so when the column, the odds ratio says 7.68, what it's saying is that there's 7.68 times a person's more likely to develop arthritis with their amalgam fillings versus those without. And then there's a confidence interval around that, which shows how certain we are. And then finally, the p-value. The p-value assesses, is this basically due to chance? If it's 0.05 or less, we say it's statistically significant. As you can see, that value is highly statistically significant. So just to summarize again, it's significantly associated dental amalgam exposure with the risk of arthritis diagnoses. The columns, the rows down below, that represents a model that incorporates not just the dental amalgam filling versus other filling surfaces, but takes into account race, gender, socioeconomic status, country of birth, age, education level, as covariates. In other words, these are things that might influence the various relationships that were observed. And the effect does indeed slightly get modified by those other variates. It's 4.89, but still highly statistically significant. One of the interesting things that's observed that you might expect is that age is related to arthritis risk. In other words, people that are older tend to have more risk of arthritis. And as if you remember back a slide, the amalgam group tended to be slightly older than those without amalgams. So that tends to adjust the 7.68 to a slightly lower risk to 4.89, but as I said, nonetheless, highly statistically significant. Now, this is a different kind of presentation of the data, looking at what's called survey frequency modeling, which is a measure basically of what is the frequency rate of disease in both of the groups. So on the top panel, there are about 2.5 million people reported to be diagnosed with arthritis in the dental amalgam group. The denominator, meaning how many people, in this case, taking into account people and how long they're followed, is just about 4 million, as compared to in those who have no dental amalgam fillings, 124,000 and a fraction are diagnosed with arthritis out of a denominator of 1.1 million. So when we compare those two groups, the rate ratio or the risk is about 6 times higher in those with dental amalgams versus those who don't. And again, the p-value is highly statistically significant, less than 0.01. And then we're able to, with this kind of modeling, calculate what's called the attributable rate difference. This is a very fascinating measure because it allows us to say not just what the risk is, but at a US population level, based on the number of people who have amalgam fillings versus those who have other fillings, how many additional cases of arthritis are occurring because of the amalgam exposure. And what it translates into is 5.3 per 10,000. This is a fascinating number because we can then apply it to our population, which was 165 million people, to determine how many cases of arthritis in the whole US population on an annual basis are diagnosed with arthritis attributably associated with their amalgam fillings. As the box below shows, that number comes out to almost 46,000 Americans each year are developing arthritis due to their amalgam fillings. And even more, once we calculate that population number, we can estimate the actual cost to our country of those people. And it's estimated from other studies that about $2,100 is the annual medical cost per adult for an adult with arthritis. $4,040 is the lost annual wages. Applying those lost wages and lost medical costs to the 46,000 people, it ends up being almost the total cost is $281,633,494 US dollars on an annual basis. So now, for the first time, we can not only say that amalgams are linked to a chronic disease, a significant one in the case of arthritis, but the actual economic impact of that. This is obviously, as anybody that's aware of public health, these are the kind of things that people try to always argue. Why do we use amalgam fillings versus composites? And they keep emphasizing cost and ease of use and those kind of arguments as to why amalgams continue. Well, I would now argue back, what's that cost now factoring in the 281 million annual dollars attributably associated to the amalgams just from arthritis as an outcome. This is another analysis, as I mentioned, looking at dose dependency between amalgam filling surfaces and the risk of arthritis. So in this particular analysis, we're not even just analyzing number of filling, we're getting down to the surface level because that's how NHANES records it. And when we do that, we find that the odds ratio is 1.033. So in other words, there's about a 3.3% increase in the risk of arthritis with each amalgam filling surface that a person has, but it's not statistically different. And when we take into account other variables, as we did in our previous analyses, like race and gender and the like, it becomes even less significant. The effect goes down, and it's only 1.7%. It's not significant. If we take into account even other fillings, it becomes less. So the dose dependency of the relationship between amalgam fillings and arthritis, based on this kind of modeling, does not appear. But when we break down the raw data, what we find is that this is what comes out, and this is truly remarkable, which is that this particular table is looking at the number of dental amalgam filling surfaces. That's on the left-hand side. So we start with people who have none, and then 1, 2, 3, 4, and so on. And below that shows you the percentile of people that have those various levels of exposure. Then at each level of exposure are the number of people with reported arthritis, and then the total weighted person years, the denominator. And the right-hand column represents the incidence rate of arthritis. And what we find is that starting with 0, the original one, 1.06, that it increases to 1.15 with one surface, into 2 surfaces, now it jumps up to 5.26, and between 3 and 6, it increases to quite high levels, to 8.5, to 8.89, to 5.83, 12.7. So clearly, having fillings increases your risk of having arthritis, and it seems to reach a peak around 6. interestingly enough, when you examine higher than that, first at 6 or more, which is the second to the bottom row, it's 5.85. And if we examine people that have 13 or more, it actually drops down to 2.41, which is a significant lowering. This, we believe, is telling us that amalgam fillings are actually increasing the risk of arthritis, which mercury is known to be able to induce immunological autoimmune effects. And perhaps at high enough levels, it actually starts becoming immunotoxic, as in it starts reducing the functionality of the immune system and starts looking like it reduces the risk. That's why it's not dose dependent. So it's a very interesting piece of science. So as a conclusion to our first analyses, our study provides compelling evidence linking dental amalgam fillings with the risk of arthritis among American adults. The effects remain significant when considering covariates and different kinds of statistical modeling. And then, as I mentioned, the dose-dependent relationship is actually one that's bimodal. It tends to increase with lower levels of exposure reaching a peak, and then subsequently at highest levels of exposure actually begins to lower it. This particular study has now been submitted for publication, so we will let you know the moment it's published. And this is our second study, which we've also now submitted for publication, looking at the risk of asthma versus dental amalgam fillings.
And this one's been accepted?
No, this has only been submitted as well.
Only submitted. Okay.
Next. So this study, much like the first one, examines a chronic disease in the case of asthma, which is known to have susceptibility factors associated with environmental exposure. And one interesting thing to note is something that most people really have not considered, which is that we know that mercury vapor comes off of dental amalgam fillings, but we've focused tremendously on it going to the kidney, to the brain, all kinds of other organs. Very few people in the field of dental amalgam research have focused on the primary interface between mercury vapor and amalgams, and the human body, which is the lungs, of course. So this study actually looks at the primary organ where that occurs. In our particular study, we evaluated the hypothesis that dental amalgam fillings may increase the risk of asthma in adults, and we took again, assessment of the NHANES database. Just like before, we looked at exposures based on NHANES' description of examination of filling status. These populations are very similar to the previous study, although slightly modified based on a couple parameters. Next. And just like with arthritis, we're looking for asthma that was newly diagnosed. So we're not looking at somebody that had asthma years or decades before their amalgam exposure. This was contemporaneously diagnosed with their amalgam exposure. And we're doing that by assessing not just did they have asthma in person, but what age the onset was. And this summarizes again the flow chart, very similar to before, but just to highlight, we end up at the end with 97 million, almost 98 million people that had dental amalgam exposure, so one or more dental amalgam surfaces. Among those people, almost a million of them were newly diagnosed with asthma in our study, and almost 32 million people had no dental amalgams, but one or more other surfaces, and almost 73,000 of them were diagnosed with asthma. Similar to the previous study, we used the same kind of statistical modeling involving logistic regression and survey frequency, as well as dose-dependent assessments to evaluate the relationship. And so this, again, provides the overall summary of the groups. Just like before, those with dental amalgams tend to be slightly older than those who have no dental amalgams and other surfaces filled. Slightly preponderance of females among those with without dental amalgams. Basically the same kind of distribution across the board. And overall, at the bottom, the frequency of asthma was 2.06 per 10,000 weighted person years in those with dental amalgam surfaces versus 0.56 in those with no dental amalgam surfaces, just other surfaces. And this is the survey logistic regression modeling outcome comparing dental amalgam filling surface exposure groups, so those who have one or more amalgam fillings, versus those who have no dental amalgam fillings, just other surfaces. Overall, the risk is 4.46-fold higher for asthma with dental amalgam exposure, and the p-value is 0.021, so it's statistically significant. When we examine with covariates, this time in addition to race, gender, socioeconomic status, country of birth, age, and education level, interestingly enough, we also looked at serum catein levels. Serum catein was entered into this particular study because it's actually a measure of cigarette smoke. People have seen that cigarette smoke can actually modify the risk of developing asthma, so it was an important covariate to examine and make sure that that is not mediating the association. When we look at the covariates, as you can see, the odds ratio actually became higher in this case. It became almost 5-fold higher, and the p-value became even more significant at 0.013. This is now the frequency modeling of looking at the frequency of asthma among those with the dental amalgam exposure versus those with other dental fillings. As I said, about 1 million people diagnosed with asthma in the amalgam group, 4.8 million person years of follow-up in that group, and 72,000, 73,000 in those that had other dental filling surfaces, and total weighted person years of about 1.3 million. When we compare the relative rate or the rate ratio between the two groups, it's 3.66-fold higher, p-value less than 0.05, and the attributable rate difference in this case per 10,000 was 1.50. So again, applying that to our overall population of people, that means that 14,679 people were reported to be newly diagnosed with asthma attributably associated with their dental amalgam fillings. And just as we did before, asthma has significant direct costs, over $3,200 per person per year. So that would mean that in an annual year, based on the 14,679 people, the cost would be $47,838,861 US. And if we assume that asthma over a period of time, like 25 years, that would translate it over almost $1.2 billion to the United States. And as far as the dose-dependent relationship, in this particular case, indeed, dental amalgam surfaces show a dose-dependent relationship with asthma. So meaning that the number of fillings in one's mouth directly mediates how much risk they have of asthma. The unadjusted model and the one that adjusts for all the covariates are roughly the same. What it's saying is, in the first one, the risk is 1.073, or there's a 7.3% increased risk of asthma per dental amalgam filling surface. Kind of an amazing piece of science to be able to do that. So if you have a patient who comes in with a certain number of surfaces, you can actually determine their specific risk of developing the condition. And as I mentioned, the two later models adjust for various covariates. Basically, they don't change the relationship very much. And even accounting for other surfaces, in the bottom model, that's kind of interesting. So in other words, do people having other dental material other than amalgams increase, decrease the risk? And as you can see on the row that says total number of other filling surfaces, the risk is 0.96, meaning that it doesn't increase the risk. If anything, it's slightly below, but no difference. And this is the same kind of frequency summary we made before. The left-hand column represents the number of dental amalgam filling surfaces, and then the next column are the number of people with asthma, And then the next column is how many weighted person years there are at each level of exposure. So those who have no amalgam fillings, their reported rate of asthma was 0.56. At 1, there was actually nobody, so there was no rate. Those with 2, it went up to 1.31. 3, 1.82 per 10,000 weighted persons. At 4, 1.02. 5, 1.24. 6, 3.76. So you can see that there's an upward trend, and those with 6 or more, it's 2.87, and 13 or more, it goes up to 3.22. So this study provides the first epidemiological evidence linking dental amalgam surfaces with reported asthma in adults, just as we observed with arthritis, and that the association remains significant even when considering all the different covariates in our study. And in this case, there was a dose-dependent relationship. So what are we really seeing, to sort of summarize now that we've done several studies? We're seeing that indeed chronic disease, specifically arthritis and asthma, does indeed have a relationship with dental amalgam fillings. So this, as opposed to previous studies, which were mostly clinically oriented, that identified a patient and they had problems, and dentists either removed the amalgams, they tried to treat for heavy metal poisoning, or they had a person that was normal and then had amalgams and had problems. This study is very different because it's looking at large populations. There was no potential bias or confounding as to sickness or healthcare seeking behavior between the groups. Everybody indeed had fillings. It was just a question of which ones they happened to have. The observed associations remain significant even when we considered other covariates, as in things like race or socioeconomic status or gender or age, all of those kind of things that might drive the effects that were observed. They didn't remove the effects. If anything, actually considering them in some cases made the effects stronger. The relationships, as I mentioned, for asthma, it was a dose-dependent relationship, which is very biologic, very expected, very powerful evidence. In the case of arthritis, it was dose-dependent in a fascinating bimodal direction, which opens the door that not everything may be simple with dental amalgams. There may be cases where it stimulates, it may reduce, it may modify. These are all things that people have never really, in any studies, examined before. And as we saw, the societal costs of just arthritis and asthma are extremely large, hundreds of millions to billions of dollars. So we need to reassess our understanding of dental amalgam's so-called cost effectiveness. As far as where to go in the future with these initial preliminary studies, they open up all kinds of new directions. First, obviously, for new epidemiological studies, we want to continue to assess dental amalgam filling exposure with many other chronic diseases. NHANES has many dozens more outcomes that can be assessed, so we can look at those and to understand the relationship. The NHANES also provides us the ability to begin to examine the biological mechanisms, meaning that if we find a disease like arthritis or asthma that's linked to mercury exposure from dental amalgams, NHANES collects clinical and laboratory data. So for example, does it matter how much mercury people have in their blood in this linkage? Does it matter what their detoxification status is? Does it matter other exposures to other drugs? All of these kind of data points are collected in NHANES. And so now for the first time, we can integrate them into our studies to actually understand how A goes to B, goes to C, goes to D, which may give us great insights into not just that there's a risk, but if you have certain susceptibility or other exposures, these enhance or reduce one's risk of developing adverse effects from amalgams. And finally, the data that's available, and it will become available in subsequent years, is to actually assess the demographics associated with dental amalgam fillings. In other words, who is making the choice, either voluntarily or otherwise, to get these fillings, what modifies that, how does it change over time? Is amalgam filling use going up? Is it going down? What indeed is happening? And so that's really our talk for today. One final thing just to mention is that with this kind of new knowledge, I think that we will be able to turn it to other databases as well. Now that we kind of understand what we're looking at and how to study it, there may be additional databases beyond NHANES that will give us insights as well.
Okay, thank you, David. Thank you, Mark. Everybody just gave you a round of applause. I don't know if you can hear it.